So the final talk in this session on, and to conclude our element of AKI, is going to be Jennifer Bezaire. She has been a traveling perfusionist now for a little while, but actually started in the performing arts before she became a perfusionist. So I expect to see lots of lovely movements as you talk through what you're going to do. So it's a pleasure to get you up here, and you're going to be looking at what markers do we use to actually define AKI, and particularly NGAL. So, thank you.
Good morning, everyone. Thank you, Richard, for the lovely introduction, and happy Perfusion Week, everybody. Thank you for coming to my talk this morning. It's nice to see so many familiar faces in the audience. I have no disclosures except this is me when surgeons try to ignore me. Oh, where's the sound? I need the sound. Okay, these are all the things that I want to get through this morning for you, and I appreciate the other two presenters that covered the pathophysiology and a lot of the background, because I have a lot of other things to cover this morning. So we know that AKI is an adverse outcome in our patients, and it increases morbidity and mortality. We have no definitive prevention or treatment, and clinicians are still using creatinine and estimated glomerular filtration rate to evaluate renal function in our patients. However, this ignores the fact that tubular injury precedes a significant rise in creatinine, so you have to lose at least 50% of your kidney function before we'll see it in your creatinine and glomerular filtration rate results. This delays the treatment of AKI, and creatinine rises very slowly because of that 50% requirement, so it's usually 24 to 72 hours following renal injury that we are able to see that the patient's experiencing that. In contrast, neutrophil gelatinase-associated lipocalin is detectable within 1 to 3 hours following renal injury, and this makes it a potential predictive and diagnostic biomarker of AKI in our patients. So the hypothesis of this project was that serum and urine NGAL levels would be earlier rising diagnostic biomarkers of cardiac surgery-associated AKI compared to serum creatinine. So it was a prospective study. We enrolled 334 bypass-supported adult cardiac surgery patients. 30 of them developed AKI according to KDIGO's 2020 criteria. From the remaining 204 patients, we used a match design to select an additional sample of 30 patients based on age, gender, BMI, Euroscore, their pre-bypass risk factors, kidney function, and the type of surgery that they were having, so that we had a final sample of 60 patients, 30 in the AKI group and 30 in the non-AKI group. We looked at urine and serum specimens for NGAL pre-bypass, 10 minutes post-bypass with the protamine sample, and 2 hours post-bypass. Then we measured creatinine pre-bypass, 2 hours post-bypass, 8 hours post-bypass, 18 hours post-bypass, and then every day until the patients were discharged home. So for about 5 days is our standard protocol. We calculated glomerular filtration rate using the KDIGO 2012 CKD-EPI equation, and I measured the NGAL in vitro via ELISAs. So this was some benchtop stuff that we were doing. The criteria that we used for AKI classification was KDIGO's 2020 criteria. So that was a serum creatinine increase of more than or equal to 50% within 7 days, or an increase in 26.5 micromoles per liter or 0.3 milligrams per deciliter within 48 hours. We elected to not go with the urine output criteria because it hasn't been well validated in the literature. So we went with the more objective, accurate measurement of creatinine for classification of AKI. And this is the moment everybody's been waiting for, the results. So this table shows you the demographic and clinical characteristics of the patients with and without cardiac surgery-associated AKI. There were no significant differences between the two groups except the number of males and females, and after listening to the first presentation this morning, I might know why now. Next shows you the types of procedures of the patients that were in the AKI group. You can see it's mostly cabbages in our center, or cabbage and combined valves, and a few isolated valves or combined valves. The operative and postoperative characteristics of the patients with and without AKI are shown in this table, and there was no significant differences between them. So we did look at bypass time, cross-clamp time, prime volume, fluid balance, lactates on pump, post-operative lactates, ICU fluid balances, ICU time, and ventilator time. And the only difference was ICU time overall. The AKI patients spend longer in the ICU. This graph shows the blood products transfused in patients with and without cardiac surgery-associated AKI. So we tracked red cell transfusion, plasma, and platelet transfusion. And there were significant differences between the groups for all types of products transfused. I looked into this a bit further with a univariate logistic regression analysis, which suggested that the blood product transfusion was predictive of developing cardiac surgery-associated AKI, with each type of product independently associated with developing AKI. So in this cohort of patients who received homologous red cells perioperatively, they were 3.7 times more likely to develop AKI. Patients who received plasma were 2.2 times more likely to develop AKI, and patients who received platelets were 5.4 times more likely to develop AKI. And I have to wonder if single donor units would make a difference in our patient population with that. If anybody is studying that, please come talk to me, because I'm curious. I went further into multivariate logistic regression analysis as well, because the correlation between red cells and FFP was 0.26. And so I found that 1 unit of red cells increased the log odds of AKI by roughly 1.38 while holding plasma transfusion constant. And the model also suggested that 1 unit of FFP increased the log odds of AKI by 0.64 while holding red cells constant. And then the correlation between red cells and platelets was 0.24. So again, I did a multivariate analysis, which suggested that 1 unit of red cell transfusion increased the log odds of AKI by 1.34, which was close to the other one when we compared red cells and FFP. And that 1 unit of platelet transfusion increased the log odds of AKI by 1.67 while holding for red cells constant. So moving on, this table shows you the serum creatinine in patients with and without cardiac surgery-associated AKI, and it was statistically significant at all time points, which I would expect because that was a part of our criteria for choosing our groups. And this is a graph model showing you serum creatinine in the AKI versus non-AKI patients. So you can see it's going up over time, and in the non-AKI patients, it stayed relatively steady. And so there was statistical significance both between and within groups at all time points post-bypass. And here is a table of the estimated glomerular filtration rate at all time points between patients with and without AKI. And similar to serum creatinine, it was significantly different between the two groups at all time points post-bypass. Sorry. This is another way of looking at eGFR. So you can see this is the baseline, and then over time in the non-AKI group, you stay up here, and in the AKI group, their renal function decreases as time goes on. This table demonstrates the time it took each AKI patient to meet the KDIGO 2020 AKI criteria, which ranged from 2 to 120 hours. The mean time was 31.67 hours. And it made me wonder how many patients met criteria after they were discharged home and we weren't following them anymore. This table shows the comparison of urine and serum NGAL in patients with and without AKI. Both the urine and serum NGAL were significantly different between the two groups at all time points post-bypass. And I show you that here too, where baseline pre-cardiopulmonary bypass versus 10 minutes and 2 hours post. There were significant differences both between and within the AKI and non-AKI groups. So I made a receiver operating characteristic curve for urine NGAL 10 minutes post-bypass. And the thing with these is that the closer it is to this, oh, you can't see the closer it is to the upper left-hand corner to 1, the better the test. So an area under the curve of 0.8 shows us that 80% of the time the model is correct. Oh, cool. Okay, thank you. Between 0.7 and 0.8 indicates a fair model and not necessarily a random chance. And it's definitely not a failed model. So this was an okay model with area under the curve 0.738. Whereas something like 0.9 would be very excellent. This is NGAL, make sure I've got the right one. Yes, urine NGAL 2 hours post-bypass. It was slightly better with an area under the curve of 0.75. And now I'll show you what serum NGAL looked like at both time points. So here we have fairly equal pre-bypass and then 10 minutes post and 2 hours post, again, statistically significant between and within the groups at both time points. The ROC curve for NGAL 2 hours post-bypass was, again, only okay at 0.731 area under the curve, just a fair model. But then interestingly, this model of serum NGAL 10 minutes post-bypass was much better. And the area under the curve was close to 0.9 at 0.8767 with a 95% confidence interval of 0.738 to 0.97. So I went further with this one and evaluated the cutoff values in a detailed analysis for serum NGAL at the 10 minutes post-bypass mark. And I found that a cut point of greater than or equal to 7,000 picograms per milliliter gave us 83.33% sensitivity, 80% specificity, and 81.67% of predictions correctly classified. So that was a Uden index of about 0.63. And in the univariate logistic regression analysis, serum NGAL 10 minutes post-bypass was also predictive of developing AKI. So it suggested that patients with a positive result were 1.5 times more likely to develop AKI. The correlation between serum NGAL 10 minutes post-bypass and creatinine at all time points post-bypass was less than 0.4, and the multivariate analysis suggested that serum NGAL 10 minutes post-bypass increased the log odds of detecting AKI by roughly 0.4 while holding creatinine at all time points constant. So this brings us to the discussion. So the results of the study, I think, clearly support blood component conservation strategies in cardiac surgery, because the data suggested that intraoperative transfusion of red cells, platelets, and plasma increased the likelihood of developing AKI. There's very little literature on the impact of component transfusion other than red cells on cardiac surgery-associated AKI. So this is an area for further investigation. My data also suggested both individual and combined impact of the components transfused in the development of AKI, which is consistent with results of other authors. Next, I want to talk about serum creatinine and AKI. So in this study, serum creatinine at 2 hours post-bypass was significantly different between the AKI and non-AKI groups. And so you're probably wondering, well, why do we need NGAL at 10 minutes if we have creatinine at 2 hours? And I just want to point out to you that it's a very small sample size, and because 5 of the 30 patients in the group met criteria at the 2-hour post-bypass time point, when you do the maths, it becomes statistically significant, but there's still the other 25 patients to consider that we could be implementing early intervention in if we're able to determine that they have AKI sooner. Also, this study showed that the time to meet AKI criteria was 36 hours approximately, which was 12 hours sooner than previously reported in the literature. Still remains a diagnostic delayed, which delays implementing treatment, which could influence the patient's short and long-term prognosis negatively. We know that AKI is independently associated with an increase in death during hospitalization and higher rates of postoperative complications. So preventing or intervening early, or at least providing treatment early, could help ameliorate some of these sequelae. I also want to talk about NGAL and AKI in the discussion. So the pre-procedural levels of urine and serum NGAL in this cohort were not predictive of cardiac surgery-associated AKI, but I really thought they would be when I ran the initial analysis on the first 6 and 12 patients as we were enrolling them. It was very close to being statistically significant, so I thought if we had a bigger sample size, it would come out that way, but it didn't. Serum NGAL 10 minutes post-bypass was the best performance as a predictor of cardiac surgery-associated AKI as compared to urine at all time points. And the cutoff value for that was 7,000 picograms per milliliter, which gave us the best sensitivity and specificity. I also thought that serum NGAL was more practical clinically because some of our patients don't produce urine while we're on bypass. And the research also demonstrated significant differences exist in NGAL concentrations between patients with and without AKI. It's a highly specific biomarker of kidney injury produced in the nephron in response to damage. And previous studies have reported that the rise is detectable within 3 hours following kidney injury and peaks at 6 hours and stays elevated thereafter. However, we were able to detect it as soon as 10 minutes post-bypass, as well as 2 hours post. So that makes me think that we're doing something to the patients almost immediately as soon as we go on bypass if we can detect it that quickly. Limitations of this study, again, include the small sample size. All of these patients had normal baseline renal function, so the findings of this study would need to be confirmed in high-risk patients with pre-existing renal disease or high-risk factors like nephrotoxic drug use. This is also a single center, so we'd like to validate these results in a large multi-center prospective trial. And in addition, there are some logistical limitations of NGAL as a biomarker. For example, it has different molecular forms depending on its origin, whether it's filtered and released by neutrophils or released directly from injured tubular cells. And the current NGAL assays can't distinguish between the different molecular forms of NGAL released by different tissues. In addition, we need a consensus in the literature on standardized periods for measuring urine NGAL and serum NGAL, and that the concentrations, we need to keep in mind that the concentrations can also be elevated with sepsis, chronic kidney disease, urinary tract infections, because activated neutrophils can release NGAL with their granular content and increase the circulating quantity of filtered NGAL in the serum, increases the amount of urine NGAL concentrations even in patients without AKI. So those are some important things to consider and control for. So we have no consensus in the literature regarding the cutoff values or timeframes for measurement for NGAL. In addition, I can tell you that measuring NGAL via ELISA is very impractical for clinical decision making. These samples were frozen, and then when I had enough to make a whole entire plate, I would then go to the lab and run them in triplicate. So we were, even though we knew that the patient demonstrated cardiac surgery associated AKI at 10 minutes post, it might have been weeks or months after I had frozen the sample that I was finding that out. Fortunately, there are point of care tests for NGAL, as well as lab analyzers, and those can deliver the results in 10 to 15 minutes. So there may be an opportunity there to apply that technology to our patient population. All current methods of NGAL are limited to intermittent sampling, which may not convincingly associate AKI with the biofluid NGAL measurements. This data could be obtained by a longitudinal continuous measurement, both in the kidney itself and in the biofluid, but it would require us to develop some new technology to facilitate continuous real-time analysis of the injured kidneys and the biofluid. So in conclusion, I want to take a moment to remind you that the average time to AKI diagnosis based on the 2020 criteria was 36 hours in the AKI group, whereas NGAL is an eligible early diagnostic tool for AKI as soon as 10 minutes post-bypass. Serum NGAL measured 10 minutes post-bypass demonstrated the best performance as a predictor of AKI. And the results supported other authors' observations that intraoperative transfusion of blood components also increases the likelihood of developing AKI. So NGAL measurement could facilitate earlier identification of patients who will develop AKI. And this study suggests that serum NGAL is a viable renal biomarker that could potentially be used to monitor perfusion and function perioperatively. And perhaps NGAL is another gateway to optimizing care for our patients. That's the end. Thank you.